You're listening to the official podcast for the Games Institute. We are a multidisciplinary research center located at the University of Waterloo, studying all things games and interactive technologies.
One by one, we'll sit down with our researchers to talk about what they're studying and what they're playing. No jargon, no word counts, just the cool stuff. Hello, everyone, and welcome back to the Games Institute podcast. I'm Tobin Rossico, the co-host and producer of this show, and today we have some very fun people here in the studio with us.
Hi, I'm Marisa Benjamin. I am your other co-host.
Hi, my name is Marina. I'm an MSc student at the School of Public Health and Health Systems.
All right, yeah, we're really excited to have Marina here with us today. So I'm going to read her official bio, and then we'll get into some questions to learn more about her and her research. So Marina is a master's student in the School of Public Health and Health Systems under the supervision of Dr. James Wallace. She holds a bachelor's with honors in health science from Simon Fraser University. Her user research study is exploring how rheumatoid arthritis patients and their physicians can be better supported in shared decision making and how digital decision aid tools can help mediate the interaction. So it sounds pretty cool. We're really excited to have you with us today.
Did we get it all in there?
Yeah, that's perfect.
All right. So what we like to do with every guest is kind of find out how they became interested in games and gaming and that kind of thing to kind of lay a foundation. So
yeah, and I know it's a little bit different for you because you don't necessarily do games research, but I'm not letting you off the hook that easy. You still have to answer our basic first question.
Yeah.
Okay, sure.
Because everybody has a history in gaming to some degree. So what is your earliest childhood memory of gaming? This could be something as simple as like Monopoly or other board games or, electronic computer games.
Rock, paper, scissors.
Okay, well, I remember playing Reversey, if any of you guys know or have played that before.
What's that?
It's just like a bunch of black and white circular magnetic.
Oh,
is it Go?
Is it like Othello?
Yeah, Othello is the other
that's
name.
What it's called.
Yeah,
I love that game. It's so simple.
Exactly. It's like a two-player game, and it's very like strategic. But it's all about patterns, and I think that's what I since early childhood I've been good at recognizing patterns. So that's what I could do. But like in terms of like being really competitive or just trying to like get more housing in Monopoly or something like that, like I'm not very good at that. But I have played Monopoly too before. It's usually like a family bonding kind of thing.
Yes. Or unbonding.
Yeah.
That was in my family.
Othello too, that one, or Reversey, that one gets pretty intense because it's like checkers and then you're adding pieces. So the more you add to the board, the more space gets taken up.
Interesting.
And the fewer
it sounds a lot like
chances-
Go, but maybe it's different.
Yeah, we have to bring it in. We should play it, Marina.
Hey, sure.
So I suppose your current research doesn't necessarily translate from games, but you are interested in like people and engagements in technology. So can you describe your current research focus?
Sure. So right now what I'm looking at is trying to understand how best to build an interactive shared decision aid, which is basically something in between a patient and a physician, and it would help communicate evidence-based research and the pros and cons of taking certain medications. And so with interactive technologies, you may know from like speaking to other researchers that basically it's usually about trying to understand the user's mental model or kind of what they perceive to be useful information at a given time point. Mm-hmm. So that's what I've been doing with patients. My scope has only really been with patients just because I haven't had time to go in and interview physicians, but that would have been ideal, just to get both sides of the equation. So it's been really interesting just to hear a lot of stories from rheumatoid arthritis patients.
Mm-hmm. We're going to dig more into the details of that research soon, but before we get there, I want to ask you a little bit about your academic biography because it's so exciting for us to have somebody who's an interactive researcher, a technology interaction researcher. So far up to now, we've interviewed a lot of people who work with games and games research, but you're our first like pure tech interaction and health research student. So can you describe where you started and what your academic biography has been like since then?
Okay. I'm just thinking how far back to go.
Whatever makes sense.
Okay. So like you guys introduced me, I'm from Vancouver, and I did my undergrad at Simon Fraser University in health sciences. So that kind of started to kind of make me more curious about sort of like how, like which types of I'm like okay, so my bachelor's basically was all about health promotion and understanding people and understanding things like geography and things like how different community groups support each other, and a lot of epidemiology, which is all about sort of understanding using descriptive statistics or qualitative surveys, sort of what is sort of their experiences with a certain disease, or even looking into vulnerable populations, and then trying to implement a program based off of the research. And so that stuff was like really fascinating to me.
Yeah, that sounds really interesting.
Yeah, especially because you're almost public health has its root in social justice, I think. And
cool. I know, I hear that and my heart goes.
yeah, so like it was almost a way for me to be part of that conversation too, just to be part of the research side of things, and show quantitative measures and say like, hey, this study is showing that there needs to be more support for HIV positive women who are pregnant or something like that. Something very specific but very targeted, because it's a vulnerable part of the population. And the thing I also kind of appreciated at the time was population statistics, because it's looking at what could we do for the greatest number of people.
That's interesting. So that's kind of like your first exposure to health sciences and what you can do with public health. And then how did you go from Simon Fraser to then deciding that now you're going to look at technology interventions?
Right. So right after I graduated, I got a job at the BC Injury Research and Prevention Unit.
Whoa.
That's not in our notes.
So I was working there as a data analyst for 2 years. I was looking at Transportation Canada data sets on car crashes and sort of all these administrative data sets that are being collected. And I was creating these dashboards just to make it easier for people to access data. So these interactive charts and these figures that would display this large amount of data. And these charts, there could be like 3 or 4 of them, and once you select a certain filter, the whole dashboard can change, and then you can be looking at let's say like age and sex, and then you could be looking at just sort of the cause of the injury or death, and then you get a greater sense of the overall picture of what's going on in a very quick kind of visual way. So right after that, I just thought, okay, so I've been in public health for some time. I want to be part of more of a greater change than just analyzing data all day. So I thought, okay, let's apply to a master's program. Nice. And I've always wanted to pursue master's studies, but I just didn't know when and like if I really want to continue, if I really needed it, I guess. And then when I was searching for master's programs, I found the Applied Health Systems program, and I really like their approach because it's a lot of systems thinking, and a lot of times in public health, at least from my experience in Vancouver, they tend to look at things more from sometimes the problems are kind of isolated from each other, and I really wanted to get more experience with like systems level thinking. and that kind of got me to Waterloo. I didn't realize that at the time, but I started off in data science and information visualization at a School of Public Health. But what I didn't realize at that time was that I was actually really interested in sort of like user perceptions and how to design these dashboards and interfaces so that it's easier for clinicians or for patients to understand health information. And then I came across Jim, Dr. James Wallace, and he was doing more of the human-computer interaction studies involving in the context of health. I guess that's where I am now. And
yeah, it's funny when you're talking about your journey. Because looking back, everything makes so much sense. Like everything led directly into the next thing, and it had this logical order. But of course, at the time, it probably wasn't like that.
Yeah, exactly. Yeah.
Yeah.
So when I'm gonna ask, what was the kind of draw of coming to Waterloo? Because I have a very unique experience of looking at grad studies and the lure of Waterloo. But what was it specifically that made you want to come study here?
That's a good question. I come from Vancouver, and Vancouver is very, it has a lot of different types of industries, but I guess I was drawn to Waterloo just because it's just such a niche and concentrated group of people who are interested in technology, and I just wanted like a different experience from what I was used to. And I also found that Vancouver, they have a lot of different industries, but yet they're not they don't go as deep maybe into each of the types of markets, or what am I trying to say? So there's a lot happening in Vancouver, but I think that the expertise there is only in like certain areas of tech. So they have a lot of marketing technologies, what else, like services, like
so
food
like
apps.
The commercial side rather than perhaps service still kind of makes it sound commercial, but more so what you're interested in rather than making a profit or something like that. Right, yeah, exactly. Okay.
Yeah.
So did you have your topic, or you kind of your master's thesis topic in mind from undergrad, or was that something that once you got to Waterloo and kind of hunkered down and you found maybe through classes or discussion with others that there's this area you could research? Kind of where did your interest in what you're studying come from? And what specifically are you studying in your master's thesis?
So I think maybe it might have started with my honors thesis in undergrad. So part of my honors thesis was looking at longitudinal data and understanding whether implementation of a housing first approach for homeless individuals with mental disorders would help in terms of their mean quality of life scores. Okay. So it was like a very aggregate kind of number for quality of life. Okay. But of course, it's not just like one number, right? When we're looking at like quality of life. But that's what I was doing just for the research side of things. And I was producing these really kind of boring looking charts. And it was all in this program called SAS and R. And it's just, I just thought that it could be communicated better and people would get more engaged if there was some kind of more of an interaction or some kind of visual appeal to the charts, because I saw the power of charts back then too. One kind of statistician that kind of inspired me was I think what's his name? Edward Tufte. Okay. And he would create these different types of charts and tried to kind of like spark a revolution, I guess, in charts and sort of display of information.
Right.
And I have a lot of friends too in Vancouver who are like user experience researchers, UX designers, and so that's always been at the back of my mind, you know, how to deliver information in a way where people would be really engaged, and also it would help them.
Yeah, that's fascinating, because that's basically what Marissa and I do as well, just in very different facets.
Yeah.
How do we deliver information so that people don't just skip over it or like keep skimming, but they're actually engaged with the content? So that's really interesting.
Right. Yeah, we haven't thought about doing a user study with what we're doing here, but maybe one day.
Because it's perfect. So how does your research fit into the landscape of public health? And kind of, are you maybe in a new field, or is this something that is kind of old but needing to be revamped?
Oh yeah, I think it's the last one there. So yeah, I guess right now what I'm doing is looking at rheumatoid arthritis patient experiences and understanding their challenges and barriers when it comes to interacting with the healthcare system.
Okay.
And also in terms of decision making when it comes to selecting the appropriate drugs for their symptoms. And I would say that just the implementation, or just sort of me trying to understand the user needs, would also help me to understand how to design for them better. And I think that might be like a relatively new field in public health. Right now it's sort of categorized as the health informatics kind of field, but of course health informatics, it could encompass a lot.
Yeah,
it's
that's
not
too
just
broad,
right,
for what you're trying to do.
Right. And I think a lot of people, when they think about health informatics, they think about, oh, it's a quantitative thing, it's all numbers, data, but it's actually also how do you deliver that information to specific users in the right way, which is qualitative.
Right.
And my study is qualitative. So yes, it's a new field, but also I feel like there's like a big push for these types of technologies, especially in Waterloo. There's a lot of support.
Can you walk us through your study? What did it look like?
Okay, so I recruited a sample of 14 patients from the Canadian Arthritis Patient Alliance, which I'm really grateful for. So in Canada, the kind of two pretty big sort of advocacy group and arthritis group is CAPA, the Canadian Arthritis Patient Alliance, but also the Arthritis Society. So I feel like they sort of cushion whenever there are gaps in the healthcare system for arthritis patients. So anyway, I recruited 14 patients and I interviewed them over Skype mainly, and it was an hour long, and I tried to understand sort of their experiences with the healthcare system, but also their own lived experience. So that's actually part of my thesis, and how with shared decision making, a lot of the times you need to also factor in the patient experiences, because they're probably the expert with their bodies, so they know what works, what hasn't worked, and what might work. And I guess the goal of shared decision making is to combine that with the physician's clinical expertise and the evidence out there. But the most complicated part about this whole process is that the physician's visit is only usually 10 minutes long.
Whoa.
Holy cow.
Yeah.
That's surprising.
Right, yeah. So that's a challenge. How do you fit in something called shared decision making into a 10-minute consult? It's already a tight constraint. And so I think out of the study that I conducted, I think that there's a lot of other opportunities using technology to support what what could be outside of the 10-minute consult. So with the use of technologies, we could, do something to connect these patients together, maybe, or even use these technologies for education so that they can learn on their own and then come to the doctor's visit more informed. But I'm still in the middle of analyzing a lot of the data, so the concrete results are yet to be clear, I guess.
We'll have to, at the end, throw in something in the show notes maybe about where we can direct listeners to go and find those results once they do.
Stay up to date with what's going on.
Yeah.
So what does the term shared decision-making mean?
Yeah, because you talk about how it involves a decision between the patient, between other evidence, and between the healthcare professional.
Yeah, some kind of physician. I imagine family might be involved in there to some degree.
Yeah, but is there anything missing from that definition?
Okay, so I think you guys basically got the definition right. So the part that makes it a little bit more complicated in my case is that rheumatoid arthritis is a chronic disease, so it happens over a very long period of time.
Right.
And so with rheumatoid arthritis, I think that these drugs called disease-modifying anti-rheumatic drugs.
Mm-hmm.
Disease-modifying anti-rheumatic drugs.
You got it. Or DMARDs. Yeah, so these come with a lot of side effects, and they usually fatigue the patients, or they cause nausea or a bunch of other side effects. So there's that they have to deal with daily, on a daily or weekly basis. And then they are also concerned about joint damage. So over a long period of time, if you don't keep taking the drugs consistently, or there are some patients where in the 2000s or early 90s, the drugs weren't as developed, so they didn't have as many choices for medication. And so right now, some of them have joint replacements because they didn't have access to the medication. Sorry, I think we kind of went off on a tangent there a little bit. But
you illustrate what shared decision-making could look like, because it's a combination of knowing what's out there, developing what's out there, hearing about people's lived experiences, taking things into account in a mutual conversation. And now knowing that the appointments are only 10 minutes makes shared decision-making difficult to imagine as a very viable thing.
Right. Yeah, that's exactly what a lot of the patients have expressed to me. So they like the idea of it. They want it to happen, but yet there's these constraints already in place that are very hard to change. It's usually on a systemic level or cultural norm level. And so my challenge is really, how do you design within those constraints? I also just wanted to supplement the answer I gave before about shared decision making. So with my study, I'm really trying to understand what the current process is between patients and physicians, and then trying to understand their challenges, barriers, and kind of wants and needs. So what they wish could happen between the patient and the physician, or maybe if they want more support outside of the clinician's office. And then also introducing them to the RA navigator within the interview and seeing what they think about the tool. And then my goal is to, once I understand their process and existing sort of mental models, I would design the tool in such a way where it makes sense to implement in the existing processes. And so it sounds like a kind of complicated process and interview structure, but it's really getting at not just like putting a technology and throwing it onto RA patients, but more kind of seeing from their perspective first and understanding, okay, so where are they coming from, and what could help as an addition to their current procedure.
Okay. Yeah. Yeah. That just set my mind buzzing a little bit, because I know that you work with a specific database. And actually, can you tell us a little bit about that before I dive into the next part?
Yeah, sure.
What is this tool that you use?
All right. So there's a previous student of my supervisor's who created this tool called the RA Navigator tool.
RA Navigator tool. Is that rheumatoid arthritis navigator
yes.
tool? Cool.
It's a decision aid which features a bunch of medications, and it has pros and cons of each, and it'll kind of list all the side effects and expected improvement by taking the drug, and it's all evidence-based, but it hasn't been evaluated yet. And that was part of my job, to see if people could see it being adopted in the doctor's visit or even before or after.
Yeah, because in that case, if this tool could come in, then maybe it could get around the fact that this third component, the evidence-based, has to be the intermediary between the physician and the patient. So if the patient could understand the evidence surrounding rheumatoid arthritis studies, then maybe they could streamline the process of going to their doctor to learn everything, and that shared decision making could happen faster. So where you come in to study that tool is really important.
Right. Yeah, and with software development too, it's not just one time you study it and then you're gonna redesign it. It has to go through many different iterations before it's actually being implemented. And especially with a medical tool, the information needs to be accurate, and it's also really important that there's no misinformation either of the evidence or of the interface itself.
Or even misrepresentation of correct information.
Exactly. Right? Yeah.
So what exactly were you looking for in terms of the user experience with the data set or with the tool?
Okay, so with sort of my interview, I kind of started to ask them first more about how the consultation looks like right now, and then sort of what they imagine, or what kind of other topics they would want to talk about if they could with a doctor, and which parts they liked about the consult, which parts they didn't like about the consult. And a lot of what kind of came up were these psychosocial factors that are not being addressed in the medical visit. So things like family planning, so some of these drugs affect fertility in males and females.
Oh. Yeah. That's interesting, because then you have to look at the patient holistically, and you can't zoom in on one thing, which it actually complicates a pure user research study where you don't want things like confounds, but that's an important consideration.
Yeah, definitely. And like along with that there's also mental health that people struggle with as well, just because this disease, it impacts them for, it could range from them being experienced for 2 years, right, 10 years, 30 years. So it can affect them on a mental level, especially if they aren't able to find the right combination of drugs that works for their body. But some people are really lucky, and they're able to just find the right combination of drugs and be stable for a long period of time. So it really depends. And then another thing that came up was also sexual health. Because you're fatigued all the time, it impacts that part of the relationship dynamic with their intimate partners as well.
Yeah, and that's very important.
Right. Yeah. So yeah, I found what I didn't expect, I guess, out of this qualitative study.
Yeah, because the person walks in as a person, a full person, and you have to take that into account. So that's great that those types of considerations emerged, because now in the way that you reflect your research, you can show like, hey, I know that you're looking at rheumatoid arthritis and shared decision making, but there's all of these other things that the patient needs to bring into the conversation as well.
Right, exactly.
So why do you study arthritis?
That is a good question. I actually sort of took on the project because Jim, my supervisor, he had this tool, and he wanted the second iteration or an evaluation of the tool, and it happened to be arthritis basically. But I don't know, I always find different kind of subsets in public health to be really interesting. Like I've been in cardiovascular health before. I've been in COPD research before, which is chronic obstructive pulmonary disease, which is lung cancer and or obstructive lung disease.
Right.
And so I find studying arthritis is also a really kind of another subset of public health, and I found it. I don't know, I guess I'm a little bit of a nerd in that way. Like I just loved like delving into like one really intense topic.
Well, rheumatoid arthritis is common in my family, so we appreciate you.
So I wanted to ask, you mentioned earlier that you have some friends still in Vancouver who do UX research or design and that kind of stuff. What have you noticed are some of the differences between, or similarities between, kind of what they do and what you do inside of a health, like a public health context? What are the similarities of what you do, and what are the differences in terms of research and design?
That's a good question. That's an interesting question. So I find that their minds are usually more abstract, and they tend to sort of iterate faster maybe because research takes a longer period of time. I feel like my mind works a little bit more where I'm just more paying attention to all the details and whether or not this method makes sense or not. But I mean, obviously, like UX designers and that field too, they have their own methods too.
Right.
It's just a quicker process because they're also driven in like a commercial space. What else? I feel like, well, I mean, for one thing, UX design, it needs to incorporate a lot of the aesthetic and visual elements and also the functionality of the interface. But they have like a heavier sort of weight on aesthetics.
Okay. Do you feel that you're safer to take your time because it is within the public health space, it is more necessary to kind of get it right and have a functioning product rather than maybe a commercial thing where it's like, we can just roll out an update so that somebody can,
out by December.
so they can customize their pizza a little bit more. But like, is there kind of an ethos behind what you do versus, a food app or something like that allows you to take your time so that you can get it right and make it the best it can be?
Yeah, definitely. I think also with the background in public health, people tend, I tend to be really careful when it comes to interpreting results and making sure it's the right method interpretation and whether or not there are any biases and things like that. And I think it's something to do with my kind of search for truth. It's always about that versus just pushing through and just producing products right away or being kind of constrained by that deliverable. But I don't know if that really answered your question.
I think so. I would agree that in your sphere, it is the truth and kind of the best practice versus the novelty of a product that is ultimately going to make the most impact.
Right.
Because if you do get it right, it will last.
Yeah, exactly.
Presumably a lot longer than something that's like hip and new and fresh.
Right. Whatever. Yeah, and that's actually exactly why I don't see myself in another field it would be hard for me to be motivated, I guess, continuously if it was maybe another space that was more about just quickly just pushing
out these things to get on the new or new app list or something like that.
Yeah. I think this is also why it's really important to have the context of how you found this field and this research direction. You came to it because you saw a need within public health.
Mm-hmm.
Whereas for some other people, they might have come into it because they were really, really interested in user research, which is the opposite end of what you're trying to do. And then they found public health as an area where they could start merging the two. I mean, not that there are many individuals who are working in this space, because it seems to be very niche and important, but niche. So you coming from public health, your motivation seems to be that you are trying to mobilize or engage with people in the evidence way, or engage people with the evidence that makes sense in their lives. And it's less about like the novelty, as Tobin was saying.
Yeah, definitely. I would agree with that. And I think there's also definitely something to do with giving a voice to these rheumatoid arthritis patients as well, because like at the end of the interview, a lot of them say, well, thanks so much for studying this, we're underrepresented, and it's such a complicated disease. It could last like a really long time. It could take over their life basically, and there's just so many different types of I guess cases, user cases or patient cases. So that also kind of ties into needing to cater to very specific different types of users, or being able to be flexible with one design. And it just speaks to the fact that you can't just implement a one size fits all onto these patients.
Yeah, and especially since it is going to be something that a patient will need to have over the course of a long period of time, there needs to be attention so that it can last.
Right. And exactly what you're saying. It's like a dynamic disease, so it's gonna change over time, even though it's the same person, right?
How do you plan to publish the results of your research when you do have that ready? Do you have any public dissemination plans so far?
No? I don't have any plans as of yet. I'm just gonna take it one step at a time. But I hope that the work can get published in CHI.
Yeah, I was going to ask if you were targeting CHI, which is the Computer-Human Interaction International Conference that happens once per year.
Yeah,
that would be a really good target for you.
Yeah, I mean, I could also target other kind of patient journals, or more of the kind of health informatics journal out there as well.
I wonder if any UX design conferences would be, some additional UX design conferences would be a good place for you, because then you can start spreading the message of what you can do in the public health space and start inspiring more people.
Right.
Yeah, I'm all about that public dissemination too. Do you think that there's a way to bring your work to a public audience? I mean, you're currently doing it, but do you have any thoughts about whether or not you could be writing like public-facing articles?
Yeah, I've thought about that too. Like, sort of, you're saying to write for a lay audience?
Yeah, especially since right now you're looking at rheumatoid arthritis, but the larger conversation that you're having in your research is about how data visualization can help with people, and how shared decision making can help with the way people engage with our healthcare system in Canada.
I haven't actually considered it like super thoroughly, but that's one really good suggestion I can try out. Like, just write it like an article and submit it somewhere to get published in a newspaper or magazine.
Okay, cool. I have ideas.
So as you've gone about your research, has there been any kind of interesting nodes where you realize, hey, I could diverge here and maybe do something to kind of bolster it, or is there separate areas of the public health where what you're doing can apply? Like, beyond the rheumatoid arthritis, is this something that you found to be common for others suffering from other chronic illnesses or things like that can be applied? So basically, is what you're doing applicable elsewhere? And if so, are you interested in any of those fields?
Yeah, I would say that's actually part of what I was hoping for actually with this study. I was hoping that these results would also be applicable and generalizable, maybe to some extent, to other chronic diseases as well. And maybe sort of the way I set up the interface might help other chronic diseases. The decision aids, they've also been studied in the context of diabetes or even oncology, so cancer patients. It's just a lot of different types of diseases that these decision aids are being implemented in. But it's always a matter of, okay, how do we structure the information so it makes sense for that given time and that user?
Right. So have you looked ahead for anything in terms of research, or are you just kind of buckling down and focusing on this, and then once this is taken care of, you'll approach the next task when it comes?
Yeah, I'm just kind of taking it one step at a time. But I've kind of... I get too excited sometimes.
Yeah.
So I gotta just like focus with whatever is like right in front of me, and then
but I imagine that like once the project is done and wrapped and stuff, you'll be able to look back and have a huge list of other areas where you can dig into.
Oh
and stuff
yeah,
like that.
I'm sure there's so much just beyond that next turn.
Yeah, it's been like a really big learning experience for me. Yeah.
Do you have any highlights from doing all of this research inside the Idea Lab, which of course is inside the Games Institute? How did working with that team and working in this environment help you?
So everybody has been very supportive of me, and whenever they give feedback, it's always just coming from the best place.
Are you talking about when you give presentations in the lab meeting?
Yeah.
Those are very different than what Tobin and I are used to, coming from like an English background. Okay. When they give presentations in their labs, I'll just let you in on this insider info. They go into detail and they look at every single thing and help the person. So the person who's just presented typically stands at the front of the room, and then they all go giving their feedback piece by piece until it's basically exhausted.
Wow.
It's excellent. I'm so jealous. I wish I had something like that when I was in school.
Yeah, that does sound much better than what happens in English.
Yeah,
it's
we
like,
all support each other.
Oh, really?
Yeah.
Because nobody wants to.
Yeah, nobody wants to be the person giving constructive criticism, but that's what they're there for.
Yeah. It was also kind of a shift for me to be in the HCI kind of space as well, just because the way that you have to think or the priorities are very different from public health. And so kind of switching my mind from thinking about sort of the rigor in methodology and sample size, bias, and just all this stuff depending on the context of the situation, to sort of like more focusing on the justification of the problem in human-computer interaction and sort of the motivation behind the studies. Of course, methodology is always important in any given science. It's just that I find with human-computer interaction, it's more about, does this make sense in the context of contributing to HCI? Is this something new that we are studying, and is the research question specific enough so we can get at something? And the motivation basically is very important, I find, in this field.
And how did those lessons come to you?
How did the lessons come to me?
Was it in conversation with your supervisor? Was it observing people in your lab? Was it in conversation in the collaboration space? How did you learn that difference between HCI and public health, and how did you integrate that in your research?
I wouldn't say just like over time, just passively just being exposed to, or maybe not passively, just being exposed to just people in systems design engineering, computer science, and just being part of the lab itself, and just observing that that's actually a priority, and just to sort of like slowly switch my mindset to more of like a human computer interaction.
Interesting. Because that's one of the things that I observe, but I don't quite know how to put my finger on it, is these moments of learning through other disciplines by observing and interacting. Like that's a lot of the magic that happens here, but you don't really notice it until you're having conversations at the end of your master's thesis looking back.
Yeah.
So what advice would you give to an incoming health student?
An incoming health student.
So it could be to the GI, to the Games Institute, to HCI, or just coming to grad studies and grad school looking for some realm, but they're interested in public health.
Or what even about, somebody in high school
Yeah.
who wants to pursue a career in health and doesn't know how?
Oh, interesting questions. I would say for grad studies, I would say be open-minded and expect the unexpected. Like that sounds super scary, but for me, I found that just undergrad it's a very different story from grad studies, in the sense where after you're done courses in grad studies, you're kind of expected to develop more independence and self-directed learning. And you don't really get as much of that in undergrad. And it's more about, keeping your GPA up, or it's like, just trying to get like a high grade, right?
On the rails in the game of undergrad.
Yeah.
More so at Waterloo than I've seen in the past.
Yeah. So I would say that you'll learn a lot though through grad school about yourself, but also just it opens you up to a completely different new way of learning. It makes you actually, what I sort of understood through this one stats course I was taking is, it's when people think about stats, they think about is this answer the correct way to analyze data? But I learned at that level that it's when you're trying to model data, it's more about the justification of the model that you picked for that given data set, rather than if it's right or not.
Right. Can you make it work?
Exactly. Yeah. So I feel like that's a really good analogy to grad school. It's no longer about if it's right or wrong. I mean, sometimes it is.
Yeah.
But like the emphasis is more on sort of discussing what are the pros and cons and what can you justify using this approach.
Maybe that's why I never got into statistics in undergrad, because it was all about doing like the rote calculations of it, and you get a piece of data that doesn't even have meaning attached to it in the courses, and you just have to figure out if P is greater than or less than 0.05.
Yeah. A lot of people don't like statistics, and it took me a while to like be able to fully admit, I like statistics.
Good for you. Well, that's everything.
Yeah.
Thank you so much for joining us, Marina. Is there anything else that you need to add before we close?
No, I think that this is good. Yeah, thanks for having me.